Now, so let me introduce Maureen.
We're connected already.
We're connected at the hip, literally.
Yeah.
I met Maureen at a seedy bar in Gatineau, and our eyes met. And no?
No.
Was it our eyes? Okay.
No. Try again. Keep going.
It's a long story. But part of my mission when teaching about epidemiology is to expose you to the many facets in which epidemiology affects your lives and the various avenues of career opportunities that may be available to you should you choose to embrace the science of the gods. And we talked a lot about government epidemiologists, about academic epidemiologists, not a lot about private sector epidemiologists. And that's where Maureen fits in. So, because Maureen is a very unique individual, very unique. Can someone be very unique? Isn't unique is kind of like very pregnant?
Yeah.
So she's a unique individual in that she's a private sector epidemiologist who deals in public health surveillance. This is heavy shit. Like a couple of my grad students were going to come, but they were, so that didn't quite make it because this is very, everybody wants to do what she does in this field to some extent.
Wow, this is a good start.
I know. She wants to do what I do in this field because she gets to be with you. So anyway, without wasting too much more of your time, I give you Maureen Perrin, Senior Consultant Epidemiologist for a company I can't pronounce.
Longevity Consulting.
There it is.
We shortened longevity, which is always a bit of an awkward statement to make, but there we have it.
I'm going to mic her so you can hear her comments. And also, you haven't got the slides yet, but you will give you a PDF version of them afterwards. So, here we go.
Transfer complete. All right, good. Well, good afternoon, everybody, and thank you so much for having me, Ray. It's a pleasure to be here, and that was quite the introduction. So let's see if I can actually master the technology and walk us through this. I want to start by wishing everybody a happy National Public Health Week. Our neighbors to the south, President Obama decreed that this was National Public Health Week down in the States, so it seems appropriate that we're kind of having this conversation today. I'm sure that some of what I'm saying is not going to be new to you guys, that you will have heard it before from Professor Ray's lectures. But I want to start by kind of talking about public health and its impact on all of our lives, because it's immense, to say the least, right? So when you look at the course of your day, there's kind of touches of public health in every part of your day. You start the morning with a shower and you've got clean water. That's part of public health. You brush your teeth, you're using fluoridated water to prevent dental caries. You're eating food, and you can be pretty certain that it's safe, right? When you go down to the cafeteria and get something to eat. The roads were safe for you coming here this evening, whatever mechanisms you decided to use to get here. We're trying to reduce carbon emissions and all that kind of good stuff. And come the evening, should you decide to indulge in a beverage or two, you're going to have some safe drinking guidelines, and whether or not you choose to follow them is completely a different issue. But those are all kind of examples of public health and how it touches your day-to-day. So with that, the premise of what I want to talk about today is really peeking under the covers. We talk about epidemiology. We all know it's based on data. There's a lot of change and transformation happening right now. So what I want to do is walk through some of that with you guys. And I'm going to do double duty on my computer if I can actually make it work. So it works. We'll see if it stays that way or not. All right, so I want to start with kind of like how I got here today. I think Ray gave a good introduction as to the story, but then there's the physical arrival. So, data, information, knowledge, right? I talked to Ray, I'm like, I'll meet you there at 10 to 4. Awesome. He's like, this is the room. I'm like, okay, I've got a data point. It really actually doesn't mean that much to me in terms of where I'm going. Ottawa U campus, fine. So I did what most of us would do these days. I turned to Google. And I decided to turn that data into some information, right? Add some context to it. And I'm like, great, oh my gosh, this is so cool. Now on campus, you actually have like pictures of how you get to. I'm dating myself, and I'm going to do that a lot today, so forgive me. But they actually now have pictures, so you can see actually how to get to the room and recognize the room. And then I got to this, and I thought, Ray, am I really coming to this? Because this is the picture of the room that they have up on the website. And I thought this is a little bit more Dexter than epidemiology. But, okay. I kind of transformed it into knowledge, right? Because I've met Ray enough times, CD bar aside. I'm pretty sure that this is just kind of a temporary thing. And it's being able to kind of synthesize and look at the different data and information we're gathering that's gonna get us to where we need to go. So I'm glad that the door's a little bit more finished than what this actually is. So disclosure, background and biases, as I probably prefer to call it today, so you guys can have a sense of where it is I'm coming from. As Ray mentioned, I am a consultant working with Longevity currently. So I actually do work in kind of the private sector. But my background really is based in federal government. So I've cut my teeth in my 17 years in this working in public health. The majority of it has been with the federal government. So working at Public Health Agency of Canada, and prior to that, Health Canada, in various forms of sexually transmitted infections and bloodborne pathogens. So that's really kind of been my formative space in HIV/AIDS as well. I've always had an interest in the technology that underpins epidemiology, and that's, I think, why I ended up in private sector. So we can come back to that. I also was a university student and a water polo goalie, just to kind of round it out a little bit in terms of a bit more about who I am. And I was a hot air balloon ground crew at some point in my days here as well. I had one of my colleagues look at this talk and he said, "Oh, congratulations, you've graduated from chasing hot air to blowing it," which I didn't think was the nicest thing to say, but still, not bad. So we're still kind of in the introductory phase here, and really what I want to do is that like summary. I wanted to do like a Twitter summary, but I couldn't make it short enough. So actually on that note, Ray, you should keep an eye on me in terms of time, and if I'm going over, and you guys can do it too, be like, let's speed it up a little. I wanted to give you guys kind of a summary about like what do I want to tell you today? And really, here it is in a brief summary. So effective public health action relies on the right information at the right time. It's a bit of a motherhood and apple pie statement, right? Yeah, what does it really mean? But it is, I think, really true. When you think about Ebola, when you think about, I think you need to consider it in the context of the different roles and who's doing what in terms of what right time actually is. But in order to do the right thing, you need to have the data to inform that decision. So with that kind of in mind, one of the things that's happening is there's a major transformation underway that impacts access to those data. And I kind of want to look at three different aspects of those transformations in the information systems that provide the data. So there's a shift from paper to electronic, and I'm so curious to hear from you guys, and I welcome questions as we go, and going off on tangents if you wish to. You know, data are collected in paper form. They still are in health. And there's this shift happening towards electronic data, which is exciting but challenging. There's the creation of interconnected information systems. So being able to link the different data points and the different systems that actually create a fuller picture of public health data. And then there's harnessing new technologies, and lots of kind of really pretty neat examples of that, anything from social media to the Scanadu Scout, which we'll talk about a little bit more. All this to say is that from my perspective, when we look at this technology graph here, right, I prefer to say that we're emerging from the trough of despair. There's hope out there for us. So this kind of graph that I put, you know, kind of talks about the implementation of technology and kind of the common emotions that people feel when you're going through this sort of an implementation. So there's a technology trigger. Hey, there's something really cool out there that's new. Let's implement it in our kind of world. And there's this building of expectation and excitement, and this is going to save us all. And then you actually start using the system and you go, God, this is nowhere near as amazing as I thought it was going to be. It's painful, it doesn't work, it's actually slowing down my processes. And that's when you enter the trough of disillusionment or despair. But there's hope on the other side of it as you start to come out, the slope of enlightenment, the plateau of productivity. These are kind of, I think, a nice way of putting that you're going to go through a period of pain as you do this transition and as we see these transformations in public health, but it is going to be better in the end. So in order to cover these things off, we're going to define public health in a little bit more detail so that we're all on the same page about what it is. And then we're going to talk through those transitions in terms of information systems and data. We're going to look at some stuff that's going wrong, and we're going to look at what's getting better. And we're going to use three examples in order to do that. We're going to talk a bit about infectious disease using an example of SARS. We're going to look at maternal and infant health, which is another system called BORN. And then we're going to look at immunization, less from kind of a systems perspective, though that's still there, and more from kind of a life cycle, and that's kind of transferring some of the policy implications into real world, into systems, and then into action. And of course, we'll end with like, how awesome is the future? I did actually think about the course objectives while I was thinking about the content for this. I just thought, in homage to the purpose of the class, I'll put this up briefly. I kind of tried to work around these two things a little bit, but we'll see how successful I was in the end. So again, I know you guys were all chatting kind of before this actually started. I really welcome if you guys have questions, points of clarification, things that you want to add, please feel free to do so. I think it's more interesting to make it a bit more of a conversation than you know, kind of the one-way discussion. I don't know what your classes are normally like, but I will also ask you some questions as we go. So feel free. All right, so let's start by defining public health. We talked about it a little bit already, but this is kind of, again, the perspective of I'm really passionate about public health. I think that this is pretty cool stuff. So let's talk about, let's start by talking about the top 10 achievements in public health, and this is something that I'm going to pick the things that I like the best on this list to talk about. So what is public health? When we look at the last 100 years, what are the top achievements? Vaccination is clearly top of the list. So again, infectious disease was a leading cause of death worldwide. It's now less than 5%, you know, causes less than 5% of deaths. I Googled that data, so don't ask me about my source, because it just seems, you know, it's up on the internet, so it's got to be real. But it's a huge success. And when you look at your parents' generation, they will have experienced polio outbreaks that we don't see anymore. We're now seeing measles, mumps, and other things, as I'm sure Ray's told you about and you guys have seen. But it's been a huge success. The other thing there is control of infectious diseases. And of course, that's the advent of antibiotics has been really significant in terms of pushing that ahead. And as you've also likely heard, antimicrobial resistance is on the rise. And that's one of the larger things that I think people are worried about coming up in the coming years, about how to figure out ways of either treating or reducing, but managing antimicrobial resistance. So of all the list of things that are there, I think the message to take away from here is we've done really good work, but there's still quite a lot more to do in terms of what we need to continue. Because even the things we think we're done, like vaccination, it's not. We need to keep doing some work on it. All right. So the pom-poms are down, so let's talk a little bit more about kind of what core public health functions actually are. And, you know, the typical definition of public health from WHO is public health refers to all organized measures, whether public or private, to prevent disease, promote health, and prolong life among the population as a whole. In other words, clinical medicine really treats an individual. Public health looks at the population as a whole and is focused on preventing disease or reducing its incidence. And we can kind of look at it from a more holistic health point of view, but that's really kind of where we're at. So along the top, you have the different functions of public health, the promotion, protection, intervention, health assessment, and surveillance kind of aspects of it. And then down the left-hand side, with these lovely colors, you have some of the different domains in which public health functions. So going back to that kind of introductory comment around public health touching your day-to-day life, it's huge. Like when you look at all of the different domains it covers, injury prevention, you know, mental health, it's really, really broad. And I want you to think about this in the context of a local public health unit, right, which is delivering services and doing all of these functions across the top on a limited budget. It's a lot. It's a lot of work to be doing in one particular, with one particular group, with one budget, but it's really quite critical. So hopefully that kind of gives us a bit of a grounding, and I'm kind of not going into the specifics of it because really the point to me of showing you guys this in the context we're talking about it today in information systems is the fact that it's large, there's lots of domains to cover, which means there's lots of different data points that need to be integrated in order to get the best data to be able to do the surveillance, for example, for these different areas. So who's doing the work? I mentioned the local public health units. Couple points here. We have a kind of a public health is interesting to me because it spans, there's a point of care aspect to it, but then there's also the public health and the surveillance function, and they're kind of two different things. So point of care, you've got, I've kind of put it in the blue box there, you can simply see kind of who the roles are and who are doing the data collection, potentially doing, having interactions with individuals. Local public health, of course, provides services, sexual health services, immunizations, all that kind of good stuff. So they're providing care, but then they're also doing the aggregation function. And so the public health is that pale pink and shows you that that public health function is often carried out by the government organizations. All right, so how do the data move between these guys? Well, there's the good old paper case report forms. You know, the decision's made at source, it can gets written on with varying degrees of legibility. It's a standard tool, so at least you kind of know what the data look like, how it's relating to each other in terms of the different pieces. but it's labor intensive, right? There was once upon a time, an HIV/AIDS case report form was filled out in triplicate. I think we've since done away with that, and I hope we have. But triplicate case report forms were not that long ago. This is something I worked with in my time in the government. So enter it once, press really hard, and hope that people can read it when you send it off to them, and they don't phone you and be like, "Marge, I can't read what you wrote on the form. We need to work through it." Right? Just not an efficient way of moving data. So great. Now we've moved to electronic systems for many of these. And the concept behind this being enter once, use many times, which is conceptually wonderful. But the challenges come when what you get is not that triplicate, kind of faded handwritten form. It's this. So these are the raw encoded data, and unto themselves they're data, but the information and knowledge part's just not going to be there because it doesn't have meaning. I would argue it's actually not much better than an electronic equivalent of this. So that's like doctor's keyboard, right? And what doctor's handwriting actually looks like, or so people say, which I think is true. So in order to make sense of the raw data that are coming in from different systems, and again, this is kind of more, it could be from different points of care, but also at a kind of a federal level too, you need to be able to understand what the data in its form actually mean, and that takes a different skill set. It takes kind of an IT kind of computer background to some extent. And you need to be able to take the thinking that a human would do when reading that form, and you need to be able to code it, and you need to make it repeatable. Computers can make a lot of decisions, but in order to be able to do this example, which is a real one, it kind of takes humans to figure out what parts actually fit together. And you'd think gender wouldn't be that hard, and people could probably figure out how to code it in a way that would be common across systems. But it's not. So that's really just an example of what you would have thought might have been simple in terms of sharing data, but actually still requires some planning and some thinking to make it work. All right. So I'm going to pause there. That's public health in a really short nutshell, just in terms of laying the groundwork and kind of looking at some of the systems that underpin this and the changes. So good so far? I'm looking at you. Yes.
Yeah. Who's responsible?
Pardon me?
Who's responsible?
For?
Public health.
Does he usually ask these big questions? In what context?
Well, in data collection context. So there's feds, there's public health units, there's...
Yeah. I mean, the question of who's responsible, I'm pretty sure you could answer this question as well as I could. So I'll answer and then you can add in. But I mean, the responsibility, one of the things that I've always found interesting is the responsibility for collection is legislated at the local and provincial levels. So if a physician or a lab diagnose a case of chlamydia or a notifiable disease, they must report it. Whether or not they actually mandate what has to be reported and how it has to be reported varies by jurisdiction. So in Quebec, they actually tell you, you've got to report this and you've got to report these pieces of data. And you've got to report it in this period of time. There is no such legislative requirement at the federal level. So basically, jurisdictions who take the time, provinces who take the time to share data with the federal government, generally do it because it's a good thing to do, not because they have to. And that means that they'll basically give you what they want or what is convenient for them. There's no kind of standardization or conformity across the provinces because they are required to do it. They do it because they want to do it for the good of public health.
So when the WHO compiles its long list of indicator data for Canada, it's incomplete. Mm-hmm.
Yeah, Ray's comment was when the WHO compiles its list of indicator data for Canada, it's incomplete, and sometimes it is. Yeah. I don't know if you have any other examples you'd want to add.
No.
I think he's enjoying the part of like being in the front of the class. Yeah. Okay. So let's look at some examples of this whole transition idea and kind of what it actually means. I appreciate the question because I was kind of trying to figure out what the right level of information is without going into too much detail, but also not being too high level that it doesn't actually help you guys see kind of what some of the opportunities and options are out there. Because really, as Ray kind of alluded to, that's what I'm hoping one of the things that you guys walk away with is epidemiology is awesome, public health is fabulous, and there's a lot of exciting work that needs to be done in the field. So All right, so let's go into the examples. So the right data at the right time, as we kind of commented on earlier. This is an assumption that was published in the Naylor report, and the Naylor report came out after SARS and was a really kind of deep analysis of what went right, what went wrong, and has driven a lot of change as a result. And so one of the quotes from there is, since its outset, public health practices depended on health information, and information in turn presupposes the existence of surveillance systems and organized data. Not always a safe assumption, I think, is what we're kind of getting at today. So here's kind of the data exchange. And again, this is kind of harkening back to the paper versus electronic world a little bit. Just in terms of your experience and knowledge, how many of you guys know what an EMR is? Or what the acronym is? Put your hands up. Yeah, okay, see a couple. Okay, good, excellent. How many of you guys have an yellow card, your immunization card? Oh, okay, good. I would expect this to be higher than the average kind of response. How many of you guys have taken your immunization data and put it into the Immunize.ca app? How many of you guys know about the Immunize.ca app? Okay, a lot less. Interesting. Do you have it?
I didn't even know what it was.
Okay, I feel like my job here is now done. If I've given him that, we're good. We're good. Yeah, there's a new app. I don't talk about it a huge amount, but it is certainly something. So the point of this is to say that primary point of data collection, so the electronic medical records that are used by physicians to actually capture data, are now, the good news is they're largely electronic, right? It's largely electronic medical records. There's a lot of variability. Each jurisdiction actually there's been a lot of funding put into it, but there's a lot of variability in terms of how the data are actually collected. Is it standardized? Is it not? Do you use heart attack? Do you use myocardial infarction? Do you just write it down, kind of typing? Do you put it in a codified field? So there's a lot of variation at that kind of point of care, and then the data are going to move along. And again, mostly electronic, but some paper there too. So we're going to look at the three examples we're talking about, kind of the elements of success, if you will. They're looking, were you going to use the elements of project success? The whole concept is that a fool with a tool is still a fool, so I'm talking about information systems, but it's more than just that. It's the people who use them. It's the processes that underpin them. That's what actually are going to give us the great data that we need in order to do our analysis. So, you know, the analogy, of course, is that if one of your three factors is shorter than the other, you end up with a tippy stool. So you need to actually be able to balance that. And you've got a little bit of room, because 3 legs will still give you something, but if you're not careful, you're going to fall over. So perhaps that's kind of the analogy of the stool. So we'll kind of keep that in mind as we go through. All right, how many of you guys know about SARS? Okay, very good. So severe acute respiratory syndrome, outbreak, massive kind of event in 2003. Just pulling out, kind of, is this actually part of an interim report? So this is an epi curve, because I don't think you can give a presentation to an epi class without throwing up an epi curve. So here it is, number of probable cases, and this was kind of an interim result because it's only 250 cases in the end. There were much more, 44 deaths. In terms of this being an example from paper to electronic, so I actually was deployed down to, this is my old war stories, so bear with me for a minute. I was actually deployed down to the Ministry of Health in Ontario, who were hardest hit by SARS, to support in the response. So this wasn't that long ago, from my world anyway. You know, I'd been out in the field for a bit. I was ready to go help, and I thought, all right, I can go down, I'm going to do some data analysis, I'm going to pump out numbers, I'm going to create epi curves, it's going to be fantastic. Because there were daily press conferences, you guys might remember or know or have read about, if you weren't actually worried about these sorts of things at this point in your life. There were daily press conferences, and that the economic impact to Toronto was massive. So having that right data and having it at the right time, which was daily, was critical in terms of the decisions that were being made at that point. So these sorts of epi curves were produced using an Excel spreadsheet. And the contact tracing was done using Post-it notes. Yeah, that's one of the stories that has come out of here, right? Is you had all the field epidemiologists that had been deployed down, And the tools that we had, I'll go into a little bit more in the next slide, but the tools were insufficient to actually allow electronic data capture. So there's pictures of walls in the headquarters that the field deputies were using with Post-it notes. And they would take pictures of those Post-it notes, because sometimes Post-it notes, they fall off, and that's not very helpful in terms of doing your contact tracing. But this was part of this outbreak. So, you know, I think that whole trough of despair thing was kind of applies to this example to some extent. And so as part of the Naylor report and some of the observations that were made when we came out of that intense period of needing to produce data and just to manage and just to get the job done, which we did, were these observations. So the existing system, because there was an electronic system, it was DOS-based, you know, not pretty, but the existing system was deemed insufficient. And the comment from the medical officer of health, Sheila Vassar, was, we're using a 19th century technology to deal with a 21st century disease. Because the existing system wasn't sufficient to actually allow people to collect the data electronically and to kind of use processes, it resulted in a proliferation of tools and processes. So everybody's kind of doing things a little bit differently. And when it came to the ministry level of trying to aggregate and roll up data and create a picture of what that outbreak looked like across the province to see if the travel ban could be lifted, it was nowhere near as smooth or perhaps as timely as it could have been. You had people working 18-hour shifts to get the numbers together. So the other comment, and I apologize for the punctuation, is that one of the comments that came out was that the experts were handcuffed by inadequate amounts of information. And the expert groups wanted desperately to get into the epidemiology, but they had no data capacity or time to do so. And I think that's a pretty damning comment when it comes to the state of affairs. So doing my little grading thing here, when we look at SARS and kind of where it was at that point in time, technology gets a red, not good. Processes get a red, not good, and the people get green. Because people are the heart of public health, right? And they will just get the job done. Any SARS stories to share, Ray?
I was going to get a country at the time.
No, okay. Anybody else? Like, did you guys, were you guys around for SARS?
You're like 8 years old.
Yeah, I haven't done the math on that. Okay, very good. Okay, so from the fire comes the phoenix, and I probably shouldn't really be saying that because it is nowhere near as majestic and easy as it might sound that way. But one of the things that's emerged from SARS, and based largely on the Naylor report and kind of the call for action, was the development, the custom development of our own Canadian homegrown public health information system, which is called Panorama. How many of you guys have heard of Panorama? Yeah. How did you hear about it?
I work at the public health agency.
Aha! Well, then you should definitely contribute more to this and call me out on things too if you want to. What's your role?
I'm just a student researcher.
Right on. Where do you work in there? What area?
The Office of Emergency Response.
Okay. Very good. It's a small community. It really is. You can tell me if I'm burning any bridges with any of the stuff I'm saying. Okay, great. So Panorama, and I don't know if you've experienced this in your, it's not being implemented by the feds, so that's always been a point of contention with it. But I think the point here and what I wanted to say is that, from the challenges that emerge from that system, or from that experience of SARS, Panorama was developed. It will cover about 80% of the Canadian population, just in terms of its reach and who's actually implementing it. So it's being implemented in British Columbia, Yukon. They're doing it jointly. Alberta opted out right from the beginning because public health is always political and there's always fun stuff going on. So Alberta was like, no, we don't want to play kind of in this space. We're going to make our own decisions and do our own thing, right? It's there's a federal role in public health, but health is the responsibility of the provinces and territories. Saskatchewan's implementing, Manitoba, Ontario, and Quebec are all implementing. And then other systems are either under evaluation or being implemented or used by the other eastern provinces. Panorama is being used for kind of a couple of different functions in public health. So it's vaccine and inventory management, actually being able to get your vaccine or your drugs to the health units. There's the immunization management, so it actually has the capacity to record an immunization or historic immunization. There's also, so it's kind of the point of care view, then there's also the surveillance aspect of that. BC added family health to it, so, you know, auditory screens for newborns, that sort of thing. And then, of course, and I've put this last, there's the immunization and outbreak, investigation and outbreak component for Panorama, which is only partially being used in BC. So we went from a bunch of different systems to one system that's covering a whole bunch of the country. I think that this is a good thing. It's the tool itself is driving a lot of change in the different jurisdictions that are implementing it, but there's an effort across those jurisdictions to figure out the balance of, while we're putting so much effort into implementing it locally, we still want to be able to share data across jurisdictions. And it's a really hard thing to do when you've got to get all of your health units kind of on the same page to worry about that larger picture of sharing across jurisdictions. So that's coming. But it's a step in the right direction. The other transformation that's happened in terms of the kind of that electronic to paper and kind of just the processes and people that are supporting the changes, there's the streamlining of processes. So an example I would give here is Panorama's been implemented, and this is a kind of an immunization example, in Ontario. In the 36 different health units, there used to be 36 different systems used to collect immunization data. Now there's one. So what that means is that if you're moving across, your record can follow you more effectively now. Provincially, there's the development of data standards, and this is the Standards Collaborative or Canada Health Infoway. So data standards are actually saying we all agree we're going to code male, female, you know, transgendered the same way. Which seems like a small thing, but there's actually, when you start looking into disease agents, there's actually quite a lot of work that needs to be done. And while there's a lot of clinical terminologies out there, they're not necessarily public health terminology. So there's work kind of towards that, and Ontario's done a huge amount of work with vaccines. And then there's the Multilateral Information Sharing Agreement. So that's kind of a process piece, right, of when we hit these sorts of outbreaks, who's doing what, who's responsible for what, to your earlier point. There's actually a framework in place. And this was actually just signed off. Recently, so it's actually being implemented. From the technical annexes kind of point here at the bottom, it sets out what information is going to be shared and how it will be used. So maybe the indicators are going to be used. We're all going to kind of look at it similarly, but the actual specifics of the data elements, again, are not part of this. And from a federal point of view, it's kind of outside of their role. They'll help set the standards, but what jurisdictions choose to use, it's up to them. So in the end, it's better. People are still awesome, but processes are better. They're more in place. They're still being figured out, and the technology is stronger. All right, so our third example. So this is maternal and child health. This is the Better Outcomes Registry Network, or BORN as it's known. This is an Ontario system. You guys heard of this? No? Okay. This is the example of connected systems. So I made the comment earlier, public health is political. One of the litmus tests that sometimes people will toss around when they're talking about, is this a good idea or not, is this going to land us on the front page of the Globe and Mail? These guys ended up on the front page of the Globe and Mail, or pretty close to it. So this is an example, with thanks to K.S. Joseph, of origins in bad data. This BORN was born from bad data, right? And so this is one of the examples that was used. So there's this article published, you know, Toronto newborns are underweight, figures show. Okay, well, that's worrisome. It's made it into the media, which means that the medical officers of health now has their attention as well. And with some digging, and I'm just kind of skipping to the fun part here. What had happened was there was a change in the way that the data were being reported. So parents were responsible for providing birth weight to the registrar, and the registrar was then converting it into ounces. And somebody decided that the birth weight field wasn't that critical, and they actually just wanted to have one kind of additional data point. So they actually ended up, one digit for the ounces. So what they ended up doing was rounding. So the 5 to 10, 5 pounds 10 ounces and 5 pounds to 15 ounces all became 5 pounds 1 ounce. And when you actually look at the data distribution, you can see there's like aberrant spikes here. So in the end, what that meant was when they thought they had an epidemic of low birth weight in Ontario, it resulted in a bit of a public health crisis because, of course, low birth weight babies, there's something going on that needs an intervention and it needs to happen earlier rather than later. It was determined that it actually was a data error, really a human data error, and it resulted in a public relations crisis for Ontario. So Dr. David Mowat, who was the head at the time, had to kind of get up in front of everybody, and they don't really like doing that sort of thing, kind of the negative press part, and say that no, there was a mistake made in our data, and actually we don't have a problem here after all. We shouldn't be investing any effort or resources into it. There's other things that we need to be focusing on. So all that to say is that part of that kind of that data exchange, that kind of human error part, there were unfortunately a few other stories to go with that, but that is part of the reason that Born was actually funded. And now it looks like this. And so I think the thing I like about this is it illustrates all of the different data sources that are now included in Born to be able to track maternal, or to be able to track the kind of start towards a cradle to grave almost profile of patients and their interaction with with the system. So that's a representation of it. One of the other things that's interesting here is, so there's FIPA, which is one of the public health privacy legislations. Born's a registry, so they're actually able to collect, use, and disclose without consent. I don't know if you guys have talked about consent, but of course that's a big part when it comes to the establishment and one of the challenges that can occur in terms of getting the data all in one spot. So these guys get kind of, and this is of course my own subjective assessment, greens in their people, processes, and technologies, partially because they have an open model access to the data. And that means if they want, if researchers want to be able to get access to the data, they can actually apply and get it. And it's a much more open model than some of the others that we found. And this is allowing the data to be used for action. The next steps is that there's going to be connections across EMRs, the development of a child registry. So they're taking kind of the initial pregnancy and birth experience and extending it to children. So they're going to have a richer longitudinal cohort to be able to do studies on. And they're also going to start linking with those immunization cards in public health. So they're continuing to build it out and make it richer, and they're making it available to people within certain bounds, obviously, but they're actually ensuring that it can be used for its purpose. All right, so going on to kind of the new technologies and the third example of this kind of transformation. So here's an immunization model. This is very simplistic. There's this, that kind of quote that all models are wrong, but some are useful. So hopefully it kind of fits in the bill there. So the concept here is that you've got kind of policy. You've got immunization schedules that are built at the national level. Those are then taken, consumed, and changed into a program. So how are we actually going to deliver our immunization based on the kind of the best practices that have been determined? And then, of course, from that, you're going to actually do your surveillance and your coverage to see how that's actually, if the immunization schedules, if the delivery is doing what it needs to in terms of protecting the population, that's where you get your surveillance or, for example, your coverage reports, and that's going to feed back into the policy. So it's the National Advisory Committee on Immunizations, or NACI, who were publishing these lovely old books. That's kind of the history of how these guidelines were published, and they moved to an online format in 2012, which is good because the schedules that they're putting out are fairly complex, right? So here's the recommended schedule for infants and children. You can see that, and I guess if you guys, most of you are familiar with your yellow cards, you kind of know what this looks like. But the recommended schedule really covers off that kind of initial period of immunizations and then all the way up to 17 years. This is great if you're kind of on the standard path, but there are also various immunization schedules that you need if you're immunocompromised. If you come from somewhere else and you need to catch up on your immunizations, there's like an accelerated schedule. So given that if you think about well baby visits that happen in the first kind of couple of months of life, this is not the only thing that's happening at that child's visit, right? That immunization schedule. There's a whole bunch of other things too. So one of the cool things that's been happening in terms of technologies is to actually take this schedule and turn it into a decision support tool, essentially. And I'm talking about Panorama just because that's what I know and the work that I've been doing. So we call it it's called the Forecaster and Panorama. And it really is that decision support tool. So it's going to assist clinicians with looking at the historical immunizations. So if you've got that mom who shows up and goes, I know my kid had measles, mumps, and rubella, but I don't actually have any data, or it didn't get collected here. There's ways of validating that. You can put it in the system. There's also, if public health, for example, has actually administered immunizations, you're going to have that wealth of data, and you can use that to plan for what the immunization schedules are. It kind of matters on a basic level for some people. Did you guys, and who went to a school in Ontario? Lots of you guys. Okay, so do you guys know about the immunization, the ISPA, which is that you can be suspended from school, right, if you don't show up with proof? Okay, you guys are all nodding, that's good. So it actually has some pretty concrete impacts in terms of being able to aggregate and look at the immunization history and have it aggregated, because there are a number of so many letters that go out per year potentially suspending kids from school. So to know that you've actually been able to adhere to this and adhere to the right schedule for you has kind of an impact for some people. So the Forecaster itself works by ensuring that the past immunizations actually count, and then doing the future view accordingly. So if your exception path, if you don't kind of fit on that initial schedule, it will actually help figure out what your immunizations should be. And again, I think one of the challenges here, and this has been kind of a cool pan-Canadian thing, is that to take that first table with your immunization schedule, to turn it into computer logic has been a lot of effort for a lot of the different jurisdictions. This is an example of just rotavirus. And it's not even the full Excel spreadsheet, because this Excel spreadsheet is still validated in this sort of a tool. So the steps have been, you take your nasty immunization schedule, you sit down with all your experts, you actually start codifying that in terms of what it needs to look like when it gets into a computer. And it actually surfaces a whole bunch of assumptions that people have made, because people aren't as logical as a computer, so you need to be able to tease that out and kind of codify it in a way that you can put it into a computer and it can help make assumptions. In Ontario, because it showed some discrepancies in thinking, if you will, it actually resulted in legislation changes. So that exercise of taking it from that paper form into a computer had significant changes and improved what was being proposed. So this immunization, the Forecaster logic, is taken and then codified into the computer to provide that decision support tool, and that's being used in the different jurisdictions that are actually implementing Panorama right now. And in terms of forward thinking, there's the consideration of public health only provides a certain number of immunizations in Ontario. It's about 15–20%. How do you make that tool available to other practitioners who might benefit from it too? So I'm going to draw your attention to the bottom of the slide here. One of the transformations and one of those conversations, that data being used for the right people, kind of at the right time, according to their role, is that there's been calls for national immunization networks or national immunization registries. And you can see kind of on the bottom right-hand side there, it says, it's still a patchwork. And this was published March 2nd, right? We still don't have a complete picture of who's been immunized at a pan-Canadian level. Okay. A couple weeks before that, there had been another article in the Ottawa Citizen, and it's kind of tracked through. I don't know if you guys have seen it or not, but it's Ottawa Public Health it said Ottawa Public Health is not tracking children's vaccinations, and I was struck by the different point of view here. How are you ever going to get a national immunization strategy if you don't have enough support for a public health unit to be able to collect and analyze and ensure that their records are up to date? So I put this out here because from a policy point of view, from a process point of view, there are some things we need to work on in terms of that are not necessarily related to the tooling, but that really have an impact in terms of being able to look at the data. So The other thing too, of course, is the legislation. So going back to the point about the roles and responsibilities, the provinces have very different approaches to how they actually collect immunization data in their jurisdictions. Quebec has actually gone through and passed legislation that all immunizations must be put into their registry, which happens to be Panorama. Other jurisdictions don't have that same approach. So there are some significant changes that need to happen in order to support the formation of a national immunization network. And it's not just the tool. All right, so those are kind of really the three examples that I wanted to give you guys in terms of the transitions that are occurring. We're almost at time.
That's good.
Okay. Okay.
Early is better than late.
Yes. No. Late would not. Late would not be good. So. So as we kind of look towards. We look towards the future. There are a lot of changes afoot. And just to kind of look at it in the context of those three pieces that we've been talking about a little, there's some pretty cool technologies out there that have potential implications for public health. And infodemiology, have you talked about that? No? So I attended the Ontario Public Health Convention a couple of weeks ago, and it was really cool. This guy named Jesse Hirsch got up at the end, and he didn't have any slides. And we all kind of looked at him and went, how's this going to go? And it was awesome. So he's a technology guy, but he got up and he talked about public health. And so that's kind of where the infodemiology and digital disease detection and some of these ideas come from his talk. Infodemiology is really not looking at the different traditional ways of collecting data in public health. It's looking at the internet. Right, and so there's people who are coming up with these like fantastic algorithms to look at digital disease detection, and I'm not just talking about pharmacy data and searches for flu as an indicator of kind of an impending flu epidemic. It's much more detailed in terms of what they can actually collect. So that's something to maybe take a little bit of a look at. It was actually a Canadian guy that came up with the term infodemiology. Some of the other stuff that's coming is this. So the Scanadu Scout is an actual. It's basic tricorder, right? So it's based on the tricorder competition that's coming. Do you have one?
No.
Oh man, there was a Kickstarter campaign, and I was talking to somebody else, and he was like, "I have one." So it's this tiny little like white kind of circle, and you can actually use it to track your own physiology. It's got like 10 different indicators, 10 different measures it can do, and so. One of these guys, Jesse, was talking about how he's using it to collect his own personal health information data at a great level of detail. And he said he would scan himself, and then he would eat some bacon, and then he would scan himself, and now he doesn't eat so much bacon, right? Because he's actually getting this kind of feedback. So that's like, so there's that kind of like whole world. How many of you guys have Fitbits? No, because you're young and you walk all the time and you don't sit. Oh my God, it's just us. We're the ones that have these things because we're sedentary. Oh God, that's terrible. But kind of true. So just the Scanadu Scout and this ability to collect personal information is like, that is the way of the future. Apple, all that kind of stuff. The process part there is, how do you show up at your doctor and say, hey, I've got all this great data. How do you actually use it? How do you use it to help diagnose me? How do you use it to look at my history? How do we use it from a public health point of view? Not as clear. And the personalized genetics part too, right? People are actually paying to have their whole kind of the whole DNA sequencing done that's going to predict what their risks are. That's commercial data, right? That's actually going to be private data. So that's necessarily going to be available for other public health purposes. And there's a whole other kind of implication in terms of how those data may actually be used in the end, not necessarily for the public good, likely for the commercial good. So the other thing, so that's kind of like just some of the things from a technology perspective, and some of the challenges from a process perspective of actually being able to use the data for the kind of that public health part. And that's why the process part is read in a bit of a question mark, because where we go from here needs some thinking. And part of that thinking is really as well looking at kind of the people part of it. And so it's the health literacy, the internet, and the cognitive versus institutional authority. So very briefly, the concept is that you know, we have a wealth of information. And there's almost a digital divide. There's people who are going to be tracking their data. There's people who are going to be getting the Scanadu Scout, who are going to be having these Fitbits, who are going to be able to access and have all of these data at their hand. And it's going to allow them a certain degree of literacy and knowledge that other people are not going to have. And so it's going to create a separation in terms of health. How do we look forward to that from a public health perspective and actually anticipate and change and ensure that that gap doesn't actually result in inequitable health amongst these populations? So that's, I mean, this is the sort of thing that from a public health point of view, I think we need to be contemplating. The other part, and this is the kind of the comment about the cognitive versus institutional authority, public health does all these really boring, awful things. Don't drink so much. If you're going to have sex, use a condom. Get enough sleep at night. Use a helmet. You know, wear your seatbelt. It's like not really very sexy or fun, right? Nobody's really that interested. We all know we should do it, but that whole behavioral change part is much less motivating for us. And that comes from institutional authority, right? Legislated. This is what you need to do. If you don't do it, if you're smoking, I'm going to fine you, right? There's other ways of kind of getting people to change behavior. And one of the things that's happening on the internet is the Jenny McCarthy effect. So she's out on social media. She's tweeting. She's in the press. She's telling you guys your kids are going to get autism because you vaccinate them. People are listening to her. You guys know that. We're seeing all the measles outbreaks. Where's public health in there? Where's that kind of that voice? And what's happening is that institutional authority is becoming a cognitive authority. And it's the presence on the social media. It's the ability to influence people. It's actually pushing those messages out there in a way that people are going to listen to them. That, I think, is something as well that we really need to look forward to doing. And, of course, having the right data to back up those things is important. It's still coming. That's all I had for you guys today.
Question.
Yes.
So, if you had your druthers,
Yep.
I used the word druthers in a sentence.
I love druthers.
What would you do to improve public health in Canada? In other words, where is the problem?
Yeah.
If there is a problem.
I think that there is a problem. So in my view, and kind of what my greatest heart's desire is, and I should have said this at the beginning, but you guys have probably already figured out, I'm a bit of a data nerd, right? I think that the problem lies in the tension between the pragmatic and the idealistic. And what I mean by that is, ideally, what we want to be able to do is to detect a case of congenital syphilis and go, okay, this is a problem. We need to be able to have a national view of what congenital syphilis is, when what the situation is. We need to do it relatively quickly. In order to be able to take the data and to transfer it quickly is hard. Ebola, perhaps, is a better example, some sort of infectious disease outbreak. To be able to assemble and aggregate data nationally and do it quickly without a lot of intervention is something that's ideal. We all want it, and we do it, but it's not as easy as it could be, because there's a pragmatic side where the actual reality of implementing a new information system is that you have to get all of your people using the tool the same way, and they all have their own ideas about how they want to do it. So I think that if we can actually look at a longer term goal and be able to, what I would like, and I think the problem is that we want that ideal goal, it's being able to put the effort towards it such that we can actually attain it at some point in time, so that we're ready for the next SARS. Because I think we're getting better, but I don't think that we're there yet.
Political will.
Political will. But I think political will comes from the people who are actually doing the work. And being able to be resourceful and not expect the resources to be at hand, because, of course, chronically unfunded.
Any more questions? Well, thank you very much.
Pleasure.
That's great.
Oh, you got the Scanadu Scout.
Oh yeah.
Very nice.
I didn't know it was cool. I want one.
It is cool.
Are they expensive?
No, they're like $200.
How much?
They're $200, but
That's
you can
pretty
actually
good.